Thank you, Kat, and welcome everyone this afternoon. It is my pleasure to be introducing our speakers today. Jim Austin is an adjunct faculty at Artsy Institute of Executive Education at Wharton Business School. Jim is a former senior executive at Baxter Healthcare, combines business strategy and organizational development theory with extensive industry experience. His expertise is in working with senior management on strategic planning, organizational change, strategy execution, and new business growth. He has skills in coaching executives, facilitating board meetings, and delivering executive development programs in strategy, marketing, and plan execution. As an adjunct faculty member, he tailored and delivered senior-level seminars on strategy, strategic execution, scenario planning, and critical thinking at a number of leading companies, including Boston Scientific, Coca-Cola, Lincoln Financial, GE, and Hitachi. In 2013, Brown University appointed him a senior lecturer of healthcare leadership, where he heads a graduate marketing and management seminar. Mr. Austin is a business management professor at the Lake Forest Graduate School of Management, where he received the Most Distinguished Corporate Education Faculty Member in 2009 and 10, and the Learning Excellence 2012 Award. He is also an adjunct faculty in the Department of Health Systems Management, College of Health Sciences, and Rush University, where he teaches a graduate seminar on healthcare ethics. As a principal at Decision Strategies International, Inc., he led numerous projects, including scenarios of the future for U.S. medical devices, R&D priorities for a major consumer products company, a strategic plan for the American College of Radiology, scenarios of the future for the League of Southeastern Credit Unions, and the new vision priorities at Rand Health. Prior to joining Decision Strategies, Mr. Austin worked for 12 years at Baxter Healthcare, the last 4 as Vice President of Strategy Development for the Renal Division. He identified new business opportunities, facilitated annual strategy planning processes, and worked with senior management on organizational development for this rapidly growing nearly $2 billion division. Before Baxter, he was an assistant to the president for Anchor HMO, a subsidiary of Rush Medical Center in Chicago. Prior to his move to Chicago, he worked as a consultant for Arthur D. Little, Inc., where he led a number of large-scale planning, business development, and strategic positioning studies between college and graduate school. He spent 4 years as an economist planning officer in the Ministry of Finance, Botswana. We'll also hear from Meryl Moss, who serves as Chief Operating Officer of Coastal Medical. In her role, Ms. Moss is orchestrating a complete practice transformation at Coastal Medical. With 25 years of healthcare experience, Moss provides the insight of leadership necessary to continually explore new ways to deliver high-quality, cost-efficient, patient-centered care to Coastal's population of patients. Over a 5-year period, Coastal has transitioned from being a traditional group practice to an NCQA Level 3 recognized PCMH practice, and most recently, one of the handful of successful primary care-driven ACOs in the country. Ms. Moss also focuses her expertise on building a corporate culture that fosters employee engagement and accountability. She believes this is the foundation for achieving service and clinical excellence, and the way to ensure that the services delivered by Coastal Medical are consistent with the organization's mission. Ms. Moss is also an accomplished public speaker. She presents to groups across the nation on a wide range of leadership and healthcare topics. Ms. Moss studied economics at Boston University, received her master's degree in administration from Harvard's Kennedy School of Government, and is a 2015 graduate of the Brown University Executive Master of Healthcare Leadership Program. It is my pleasure to turn this webinar over to Jim Austin.
Barb, thank you very much, and welcome everyone. I'm very pleased to be here, particularly with Meryl, because what we're going to cover this afternoon is part theory, but more importantly, practice. Easy to talk about change, hard to do it. And as many of you on this call, I'm sure, are struggling with, the Affordable Care Act means significant, if not transformational change, potentially facing your organization. So what we're going to do, what Meryl and I have worked on, and this presentation we presented at the ACHE Congress last spring here in Chicago, what we're going to do is first cover what are some theories, what are some frameworks around driving strategic change. There's a number of models out there. And what I want to emphasize, I'll be covering the framework side, and then I'm going to turn over to Meryl to cover the case study, to say, how was this actually applied in her organization? And oh, by the way, Meryl is COO of Rhode Island's largest physician-owned and governed primary care practice. So while it's not an inpatient center, like many of you on the line, I know she's had to deal with physician groups, with the blend of physician, nurses, and techs, and finding a new way forward in the evolving world of the U.S. healthcare system. So I hope that both our frameworks as well as her lessons learned, what obstacles she ran into, and how she was able to overcome that. Some of this will be important to you. We certainly are reserving time for questions at the end, but you can feel free to shoot us questions on the comment box there at any point in our conversation. So, without any further ado, let me dive in. As I indicated, our agenda today is what are some change models and typical obstacles, and I'll go through that for the first 20 to 30 minutes of the presentation, and then turn it over to Meryl for Coastal Medical's journey. Most change initiatives fail. 85% of strategic change initiatives fail, according to the Center for Creative Leadership. Authors such as Kathleen Eisenhardt out at Stanford, Michael Porter at Harvard, put the number at anywhere between 60 and 80%. And the reasons are primarily twofold. Number one, communication. But number two, it's hard to change at an emotional level. What do I mean by the communication? There was a recent study by the U.S. Chamber of Commerce on what employees see lacking most in management. And this is across the board. It wasn't specific to healthcare. But two things stood out. One, management does not listen. Management wants to push. Management wants to talk. But how often does management really listen to employees? Point one. Point two, communication. 8 to 10 times the need for increased communication. And it's not the what. In the military, there's a thing called the leader's intent. The general's role is to set the what and the why of an action. What do we need to accomplish and why? Then it's up to the teams, to the troops on the ground, to the nurses on the floor, to the physicians in different subspecialties. It's up to them to develop the how. Now, certainly the how has to be defined within certain boundaries, within certain financial, strategic, ethical, whatever boundaries the organization is setting. But that distinction of the what and the why is so critical. And in particular, leaders do not spend enough time explaining the why. When we get to the models of strategic change, you'll notice all of them emphasize the vision, the purpose, the reason for undertaking a change initiative. Too often change initiatives are listed or told to folks without sufficient detail or orientation towards the why. Here's why we have to do it. Here are the options we've investigated. Here's what the Affordable Care Act is going to mean. Here's why we need to shift from a fee-for-service orientation to more of a value-based organizational approach, or however you're defining it. And so when I turn it over to Meryl, in particular, listen for not just the what, but the why. How did she get her different groups engaged? How did she keep them engaged? And what were the boundaries that she set with her team for driving the organization forward? So some of the obstacles, and this comes from the American Management Association, again, not linked to healthcare, but it's interesting, and it's a great exercise with your teams to start off by saying, why is change so hard? And then list those objectives, list those obstacles, list those concerns, and see how many of these obstacles here from the AMA appear in your list. I also teach courses in decision making. And I believe most decisions actually start in our gut, and then we rationalize them analytically or with our brains. In change, it's not just the analytic issues around change, it's the emotional side of change. Most people are pretty happy at what they're doing right now and what they've been trained to do. They know the metrics, they know the outcome, they've been schooled, they're part of a group, they feel connected. And in a major change initiative, you're shaking all of that up. And note number 3 here, confusion over objectives or expectations. At least in my experience, that's often number 1. That's where the why is so critical. Not just the what are our objectives, expectations leading to this. So, steps for driving change, 3 people I'd like you to think about. The grandfather of change is John Kotter. And if you haven't read his book, Leading Change, it's a wonderful, very easy, very approachable read, full of business examples. He argues there are 8 key stages to organizational change. You have to establish that sense of urgency. You need a guiding coalition. There has to be a vision. You have to communicate the vision. You're empowering others to act. You want to constantly seek short-term wins and then publish and consolidate those wins. You may have a longer-term goal, but as Kotter says, you've got to break that goal down into discrete elements and show that people can achieve those on a daily, weekly, quarterly basis. And then from that consolidation, you institutionalize. You don't start by trying to make enormous change in an operating group. You start by, here's the goal, here's what we need to achieve, here's the sense of urgency, here's how we're going to communicate, here's how we're going to set new expectations. But now we're breaking that down into discrete elements. And if you read Kotter, he argues, surprise, surprise, the biggest failing in most change initiatives, they don't communicate enough. And again, it's not the what, it's the why. How often do you communicate, and how do you also listen? Whenever you're starting a change initiative, at least I believe successful senior executives spend a lot of time listening. When Gessner came in to turn around IBM, he didn't start off. In fact, he was asked very early on, what's the new vision for IBM? He said, I don't want to talk about a vision. I'm not portraying that. What I'm trying to do is listen. And for the first 6 to 9 months, he visited every facility. He immersed himself in IBM, and it was out of that he came up with the idea, let's keep IBM together, but let's move away from hardware and start developing services, which has really changed the nature of IBM. But he listened first, and then he clearly articulated, here's what we need to do and why. Somebody else that I'd like you to think about, though, is a man named Vineet Nayyar. Mr. Nayyar was CEO of HCL Technologies. HCL Technologies is the second or third largest IT outsourcing company in India. And I like this book for several reasons. First, Mr. Nayyar is very honest and very personable, and just he talks about his leadership journey in very human terms. Secondly, it's very concrete. He talks about the journey, what he does know and what he doesn't know, and he's willing at various points in the change journey to say, I started some things, they didn't work so well, so I had to pull back, but I never stopped from having the longer-term sense of where we needed to go. If you get the book starts with, it's published by Harvard Business Press, the book starts with a year-end meeting, when he's coming in as the new CEO, 2004, 2005, he's an acting CEO. He doesn't know much about the company. He's only been on board for a little while. And they're looking at year-end results, and the company has grown 40%. Now, I think in most of our terms, if we were even growing 20%, that would seem incredible. So he's growing 40%, and everybody's slapping each other in the back, and this is great. But he is the new guy, suddenly stops and says, oh, by the way, how fast is the market growing? At which point there's a silence, and finally somebody says, well, we think it's growing 60%. So even though HCL Technologies is growing 40%, they were going backwards in market share terms. At which point, Nayyar says, we have to change. We have to do some things differently. And his book is about that journey. And in particular, what he tries to do is say the entire organization exists for solving customer issues. But the way to solve customer issues is to train, is to empower, is to focus the entire organization on the frontline troops, on the sales force, on those technicians out dealing with customers. It should not exist for senior management. It's not he talks about inverting the traditional pyramid, where all the resources are directed towards the field, not towards management. And so thus the title, somewhat tongue-in-cheek, employees first, customers second, and his point is, if you satisfy frontline employees, they will in fact satisfy customers. So the points that Nayyar makes in driving change are these 6 issues or checkpoints. First, what's the reality? And he never moves from acknowledging point A and identifying point B. He never moves from we were losing market share, we were going backwards. For us to be a leader, we've got to be growing as fast or faster than the marketplace. Then the how, remember my leader's intent, he establishes the what and the why. The how, the strategy, what are we going to do, was collaboratively developed. So it was developed with input from various levels in the organization, particularly the frontline troops. Many organizations look at strategy as a top-down effort, and certainly significant goals, significant trade-offs have to be made at the executive level. The challenge is, how do you pull in others in the organization? How do you get information about the market, about your customer segments, your patient segments, about technology, about changing medical practices, about regulatory issues? How do you get those if you don't bring in others from the organization as part of that strategy review process? So Nayyar absolutely emphasizes that side. Third, he talks about bridging the gulf. And the gulf is the difference between where employees are today and where they need to be for that point B organization of the future. Employees today may be incredibly siloed. Every subspecialist directs their own practice. Is that the model of the future? And if not, how do we bridge the gap? Fourth, he has this term, blue ocean droplets. Now, for those that do not know Blue Ocean was a book written by Kim and Morberg in 2005, I believe. Again, another Harvard Business Press, great book, very good Harvard Business articles on blue ocean. Concept is, typical competition is head-to-head, or what they call red ocean. The meat goes into the water and the sharks fight over the meat, creating the red ocean. Your gain is my loss. It's a zero-sum competitive game. Blue ocean is uncontested space. Blue ocean is new ways of doing things. It may be accountable care organizations in your marketplace. It may be whole new ways of developing population health, whatever. But his concept is, again, it's not major change in the sense of we're going to suddenly overnight develop uncontested ideas or business opportunities or medical practices, but rather could we experiment? Could we seed? Could we have a few droplets in our organization to see how things will work? all of you know one of the critical complaints, all of you from the institutional side, from the hospital side, from the inpatient side, all of you know that patients have a hard time getting hold of a doctor and getting an appointment. Now, many of you, I'm sure, are experimenting with electronic or online office visit opportunities. I'm here in Chicago. I belong to Northwestern Health Medical Group, and I can go online. If I have 48 hours or more, I can go online and schedule an appointment. Now, I don't have to wait for Amazon to get on to order something for 48 hours. So maybe there's a way that some of your institutions could experiment with social media, could experiment with online offerings. I don't know the impact. I don't know if it'll significantly change your operations. I don't know if it's just a nice to have or something more important. I don't know if it's even blue ocean anymore. But it's those kinds of experiments that Nayyar's talking about. Fourth, the passion. And that's got back to Cotter's urgency. If you're trying to change many, many things, guess what's going to happen? None of them are going to be shifted. Change is about clearly prioritizing. This is most critical, this is secondary, and this is tertiary. In Covey's book, The 4 Disciplines of Execution, he actually argues if you're trying to execute more than 1 or 2 major change initiatives, you will not succeed. You need to have clear prioritization, clear team membership, clear objectives, and daily, weekly calls to action to truly drive change, to truly execute. So that passion is this a priority? Is this critical urgency? Or is it just one of many things that I have on my checklist? And lastly, his concept of informing up. Part of that communication isn't just with peers and with the other levels of the organization, but also up. If you're in the senior management team, how are you communicating with the board? If you're in the senior management team, how are you keeping the CEO or the president or the medical staff informed? And as I'll show you in a moment, many change initiatives go through a valley of despair. If you're not informing up, if you're not clearly articulating, here's how to be ready for dealing with the valley of despair, things can easily fall apart during that phase. So that's model number 2. And as you hear Meryl in a couple of minutes, you will recognize a number of these key attributes when she describes the journey of change for Coastal Medical. But the one that I like, and partly because it's simple, I can remember 4 things. This comes out of MIT's Media Lab, and it's actually on how technologies are integrated into populations, which is an interesting perspective. But they argue to drive change, you need 4 things. And again, think back on Cotter and Nayyar and how consistent a number of these attributes are. Number 1, why are we doing this? What's the shared vision? And clear, consistent, can't be communicated enough. Here's why we need to make the change and what it will result, and what the results should be. Secondly, what capacities do we need for the change? I love to play golf. I could play golf all the time. I could never make it. I'm 64, and I'm a pretty good golfer. I could never make the senior PGA. I'm not good enough. I didn't start when I was 3 years old, whatever. I don't have the capacity to make the senior PGA. What capacities, no kidding around, do you need when you start initiating some of these changes? Third, that pressure for change, that urgency, that sense of what's the passion, and is this a clear number 1 priority, or is this just one of multiple priorities? And lastly, what are the steps? What do I need to do today? What do the teams need to do next week? Where do they need to be next quarter? And again, to think back on Covey's 4 disciplines of execution, he says, everybody talks about accountability. What we're not very good at is actually following up with people on an individual basis. He says teams that really drive change every week come together, every week review their process, every week hold themselves accountable to what they've accomplished or not. So if I'm reporting to Meryl and I miss last week I missed what I was supposed to get done, her conversation with me should be two things. One, Jim, how are you coming on this week's objectives? Oh, I'm going to meet them, Meryl. Great. Number two, how are you going to make up for last week's missed objectives? How often do we have that conversation? Just honest, just straightforward. We need you in this team. We need your capabilities. We need your sense of urgency. You're all important in this team, driving the change forward. How are we going to hold ourselves accountable to stay on our objectives? Lastly, before I turn it over to Meryl, I've mentioned the emotional side. In a sense, to me, Cotter, Nayyar, the MIT Media Labs is the intellectual model, is the analytic framework. But behind the analytics is the emotional side. And I would argue emotions derail more change processes than the analytic frameworks. In particular, think about the journey of change. Somebody who's comfortable in what they're doing, they have to, in a sense, to make a major change, they've got to give up the way they've always done things in the past. And thus that emotional drop in there in the middle, that valley of despair, when are we going to see something newly emerge? That is the toughest time. I won't go through the comments in the bottom for the leadership tasks, but as you think about it, if it's simply an analytic framework for driving change, you're going to miss the critical element to keep the passion going, to keep that sense of urgency, to drive that sense of commitment. One last thing. Nayyar argues in most populations, now again, he's an IT company, not a medical company, but think about this in broad terms. He argues in any major change element, there'll be 10% roughly of your population that will adapt whatever the CEO or whatever your leadership team says should be done. In the medical field, it's called the early adapters. That certain physicians always want to try the new thing. They're the early adapters. But 80% are what he calls fence sitters, or folks that are just watching to see, is this really going to stick? Is this something we've really got to do? Or is this just flavor of the month? Some executive read a new book, dialed into a webinar, came up with something new, and thought, oh, we've got to drive this. And so what they're waiting for is really the consistent, the why, the communication, the change in incentives, the change in how we hold ourselves accountable, and so on, all reflecting those shifts that the organization is saying we need to do. And then lastly, 10%, according to Nayyar, will never be there. And you've got to figure out what to do with that 10%. If you have a strong 80 to 90% supporting the initiative because it's been consistently well articulated, simply and concisely with that strong element of the why, the 10% will be drawn along. The problem is more when you don't have that 80% and then the 10 is fomenting in the background. Why the heck are we doing this? Particularly when you go through the valley of despair. So with that, let me turn it over to my friend, Meryl Moss.
Hi, this is Meryl. I hope everyone is enjoying it. Let me step back a second and tell you how Jim and I got to know each other because it was a very important time for me and for Coastal. So I decided, as did some of my other colleagues at Coastal, that we really needed to retool. And even though I had done graduate work at Harvard, that with the new healthcare transformation and all the things that we wanted to accomplish, felt that we all needed some new education. So my colleague Al Caros, who's our president, went to Yale. I went to Brown. Our CMO is in the process of applying to Dartmouth because this work is so new, and we really felt like we needed to refill our toolkit. At that time, I met Jim, and he taught management, and he taught us with other professors about how to implement change. And so since we were in the throes of this change, and I'll talk about that, I really tried to take a lot of his ideas and theories and bring them back here. And I was lucky because my colleagues said, okay, let's use it. And that's exactly what we did. So I'll step back for a second and tell you a little bit about Coastal. So Coastal Medical is a very large primary care group in Rhode Island. We've had the advantage of being primary care. Maybe that wasn't such an advantage 10 years ago, but about, I would say around 2008 or 9, we made the decision that the way that we were serving our patients, and at that time we were probably about 70 physicians and 20 extenders or advanced practitioners, that we wanted to really think about doing it differently, and looked at patient-centered medical home care and thought this could really work for us, that we really have nothing to lose because primary care needs to serve our patients differently. And at that time, we're in very much a reactionary mode. A patient would call us, we'd answer, we see if we can book them, we're all fee-for-service, we're churning patients through. We weren't thinking about who was the sickest patient or who was healthy or what kind of nutritional services they needed or whether they should speak to a pharmacist or whether we should be following them closely in the hospital. We were really traditional primary care office reacting to patients as they called us. And we made the decision in 2009 that we wanted to change that. We began to really look at the way that we got paid and said, we need to start shifting away from fee-for-service to value-based care. We need to move away from getting paid on 99213s and 4s and 5s. You guys all know, I'm sure, what the codes are. And we need to start getting paid for quality and for better customer service and for bending the cost curve. We can do that. And because we're a very big fish in the small pond of Rhode Island, we really had the market power to bring our payers together, Blue Cross, United, Tufts, and became an advanced payment ACO for Medicare, and made this total commitment, burning the boats at the fee-for-service shore to do population health management, patient-centered medical home care, and move away from traditional fee-for-service medicine. So focus on quality, customer service, and finances. I'm going to talk a little bit first about what our results were, and then talk a little bit about how we got there. And we are humbly at the beginning of a journey. This is 2015. We have been very successful in our shared savings contracts. We have been making quality measures. Right now we report on 143, and I'm going to talk to you about how we looked at that and really attacked that. But how do you change a culture that's really focused on traditional fee-for-service primary care medicine, busy offices, 23 in total, and how do you move everyone to a place where we're thinking, talking, engaging, and working with patients in very different ways? So, I got to move the slides, hang on. So this was our timeline. We started going to an electronic health record. We actually used eClinicalWorks in 2006. That really created the platform from which we were able to grow, move to pay for performance in 2007, became patient-centered medical homes in 2009. What that means is that we created these teams in all the offices, nurse care managers, pharmacists, medical assistants being elevated to promoted that with patients that you now have a patient-centered medical home team and applied for NCQA Level 3 recognition, which we received. Meaningful use in 2011, and at that time also we received the Davies Ambulatory Award for the best use of an electronic health record in the country, and then moved into shared savings in 2012, and now we feel that we're absolutely 85% of our 120,000 primary care patients are in one of our accountable care contracts. So financially, we're very aligned internally. So show you a little bit of our results. I actually can't share some of them because we just finished ACO results this year, and they were fabulous. I can say that better than what I'm showing you, but this is what we're able to show right now. So our inpatient rates dropped by 29% for our CMS population. ED use fell by 17%. Our membership rose. So during this time where we are absolutely changing the culture, moving away from fee-for-service, embracing population health, not only are we achieving drops in inpatient, hospital spending, admissions via the emergency room, our membership is rising because our patients like what we're doing. And right now, we have such a backlog of patients wanting to have a coastal physician that literally, if I opened the floodgates, we'd have 20,000 more patients that we could take on right away. They want us because of this work. You can see the quality measures. Again, this is just a little snapshot of our results before I tell you how we got there. But in 2011, we were not reporting or measuring some of the things that we felt were incredibly important. Our doctors, who are all highly trained, highly educated, very compassionate, internists, family practitioners, pediatricians, all feeling like they did great work, we were not measuring things, and because we weren't measuring them, we really weren't doing some things. Now we're able to see it. I'll give you a quick example of something that came up recently. We were looking at our COPD patients, and we were segmenting them, and we were looking at how many had PFTs, and the pulmonologist, who's a very fine pulmonologist that I work with, said, oh, of course, everyone has them. Well, guess what? They didn't, because we have not been measuring it. But as we started to measure, and we you know, the hospitals, and you guys are actually in a better situation than we were. You have JACO, and I'm sure that some of you are complaining and rolling your eyes about it, but we had nothing. Physicians really had no standards and no guidelines beyond making sure that your coding documentation was correct if there was some kind of a OIG audit. We weren't held to quality standards of any kind, so all of this was new to us. For me, these standards gave us guidelines, so I embraced, as did our whole executive team, NCQA as guidelines, meaningful use, and we have quality targets in every single one of our contracts. Unfortunately, all that enthusiasm resulted in the fact that we're reporting on 143 quality measures, and we have achieved all of them. You'll be hearing at some point how well we did as a CMS ACO, really in the top of the country. But I'm going to talk to you about how we got there. So this slide actually talks about four things: diabetic hemoglobin control, fall risk screening, which, by the way, we weren't doing at all, depression screening, and childhood immunizations. And you can see that in all of these areas, we have really improved considerably. And as we're thinking about this, we made a decision very early on at Coastal that under no circumstances would we jump through hoops for any quality measure. We weren't going to do something to get paid for it. So if it's important to do fall risk screening on our frail elderly patients, then we're going to do it. And if it's important to do depression screening and then do follow-ups for our primary care patients, then we're going to do it. And if it's important to keep hemoglobin control under 8, then we're going to do it. But if something that's irrelevant, then we're not going to do it. So that was one of the decisions that we made with the physicians in the organization, is that anything that we work on will be important. And I'll tell you, I was at a board meeting last Monday, and we went around the room and asked the board if they felt that we continue to go in the right direction. And we went around the room, and each of them had an opportunity to speak. And one of the doctors said, for me, because we are achieving quality measures, we are actually changing the health and the lives of our patients. And, you know, that just kind of makes you want to cry. So we're feeling very good about that. So let me tell you a little bit about why we needed to change. I was in class at Brown, and I was feeling like our strategy was good. Our vision was correct. We had been communicating this vision, as Jim says. We were talking about moving away from fee-for-service and moving to population health with all of our physicians and all of our staffs. But we started not to be able to meet the quality measures. We were running them and just falling short in different areas. So our corporate team, we felt like, we are the messengers, but folks are just not listening. That was what we thought. And people are just not buying into it. We're telling people that, we're being directive and saying that this is the new vision for the company, this is where we're headed, but our docs and our staffs are not buying into this new vision. That's what we thought. So we said, look, we gotta man up. We gotta be responsible and be able to hear what we don't want to hear. And so we surveyed anonymously all staff in the company and all physicians in the company, and we asked them if they, number one, agreed with the new vision, if they bought into it, if they felt we were going in the wrong direction or the right direction, and what we could change so that we could actually achieve what we wanted to achieve. And the results really surprised us, because what they said was, we love this. We think that patient-centered medical home is better than the care that we've ever provided to our patients. We love working with pharmacists and nurse care managers. We think our elderly people are getting much better care with nurse care managers in the hospital and the nursing homes working with them. The pharmacy handoffs, hospital from hospital, are working. And the idea that we get a phone call whenever our patient lands in the hospital or in the ER, and we get to talk to the ER doc about the disposition, we're making a difference for our patients. So that was all super positive. Staff felt the same. We love this new model. We feel elevated in our roles. We had done previously to implementing all these new quality measures, a lot of education and training for our medical assistants. And we taught them medication reconciliation so they could actually do it in their offices rather than have either the physician or the pharmacist do it. And we started to really think about who we were hiring and hiring a different, higher quality level of staff. And that came through loud and clear in the surveys. They said, we like this new work. We are happier at work. We're proud of our new roles. And we like the fact that we're actually on the clinical teams, secretaries and medical assistants. We feel we're more important. And so where's the but? Well, the but was, we just can't do all this work. We can't do all of this work on top of the work we're doing. And it was a big aha moment for our management team here, because we realized how dopey we were, that we had taken this new vision and kind of dumped it or laid it on top of these already very busy, maybe even overly busy primary care practices without changing the way that they functioned. It was really kind of silly when you look back at it, but I'm sure this is a mistake that's made all the time. So when we think about what Jim said, we didn't really provide the resources or the capacity. We didn't create the capacity for both our physicians and staff to be able to implement the change, which was really our fault. Coastal has already had a culture in general of inclusion. Doctors own the practice. I'm the only non-physician owner of the company. So all our physicians are owners, so they're totally bought in. And we have traditionally included staff in a lot of decision making. So even though we might have a vision that's coming from the board and our strategic planning committee, which is mostly working physicians, when we decide to implement things, we kind of pull it from the ground up, because we know that if we don't, it won't work. So we had reached a point when we were looking at our quality measures. Now, this was at the end of 2014, so this is at the end of last year or the year before, where we just weren't making them, and we had to have almost what we call a fire drill. We had to call everybody together and say, this is just not working. We're not achieving what we need to achieve, and we're hitting year end. You guys will all know that kind of feeling. We're hitting year end, so we had to pull nurse care managers and office managers and medical assistants and corporate staff, and we had to rush to try to make sure that we hit all the quality measures, and we did do it. We did do it, but it felt awful. It felt awful, and even though people wanted to say, look, we really support this new work. We know that we can make a difference if women get mammograms or if people over 60 get colonoscopies, or we reduce those hemoglobin A1Cs of our diabetics. We can't live like this. We can't continue like this. This is way too stressful. So the way Jim was talking, or what he was talking about, this created an urgency for us. So in January of 2015, we all got together and said, with sort of our heads on the table, we cannot live like this anymore. We cannot continue like this. We can't rush it to the end of the year, and even though we think that this is all good for patients, we need to start systematizing things. So our workflows were not supporting strategy. Our physician and staff were overburdened. And even though the patient experience was good, our patient surveys have always been fantastic, it wasn't exactly the same from office to office. And we were in total crisis management. And we certainly, at the corporate office at an executive level, didn't want to be here. Doctors definitely didn't want to be there. The nurse care managers didn't want to be there. Staff didn't want to be there. No one wanted to be there. So it was a wonderful opportunity, actually, for me to bring everybody together and figure out how to make a change. So given the fact that people were on board, that was really an important piece of information for us, that physicians and staff alike thought that the whole idea was good. They had bought into it. Now we had to figure out how to implement it. So what we did was we invited everyone who wanted to come to a big meeting. We said, anybody who wants to come is welcome. Secretaries, medical assistants, physicians, nurse care managers, pharmacists, corporate staff, anybody who wants to come can come. We would really like a representative from every office. We don't care who it is. It doesn't have to be the lead doctor. It can be an office manager. It could be a secretary. We don't care who it is, but we'd like every office represented. And we brought these people together, and we had 45 people show up, which was kind of nice. 45 people is a pretty nice group. And of that 45 people, about half were doctors. And we said to them, I facilitated the discussion, and I said to them, we've got to figure out how to do things differently. So first, let's determine what we really want to be. And I had been reading Nayyar's book that Jim had mentioned, and he did an exercise in this book. First, what he did was he said, let's visualize how this perfect practice could work. Well, and for him it wasn't a perfect practice. For me, that's what it was. And we did that. And people didn't hesitate to contribute. You know, we want to be able to answer the phone as soon as someone calls. And we want someone to have a same-day appointment if they need it. And we want them to even have an appointment at night if they need it and on weekends. We never want to turn anybody away. And we want to make sure that the ER always has access to us. And we want to make sure that every diabetic have all the quality measures that they need, foot exams and eye exam and blood tests, all done consistently in a timely fashion, and that any intervention is done right away. So we were able, with ease, to say these are all the things that we want to be. This is the new primary care practice of the future. What was a little disheartening, and maybe caused us to have a little despair, as Jim suggested, was when we put a mirror to our face and said, who are we? And Coastal has always had such an outstanding reputation, so people are fairly proud. But when we looked at ourselves, we thought, do we really take our phones off answering service in a timely way, and do we do that at lunch every day? Is it really true that anybody who's sick, they can be seen the same day? Is it really true that we're providing the comprehensive clinical services that we say that we're providing or we want to provide? And can we possibly hit all the quality targets? And unfortunately, a lot of the answer was yes, kind of, somewhat, not so much, most of the time. But it wasn't what we were really looking for. And what was getting in the way? Well, what was getting in the way was tasks. We were so busy, and we were doing so many tasks that the things that we would really have liked to do, well, sometimes we couldn't do. And that wasn't good. So we asked the group to really think about it. and invite others if they wanted to, and to come back and give us some really good suggestions about what they would like to see. And we had our own ideas. You know, we, as executives always do, we thought, they're going to come back and they're going to say, let's do centralized scheduling. Or they're going to come back and they're going to say, let's have a centralized call center. Or they're going to come back and say, we don't want to do this particular type of work. But that's not what they did at all. So we got them all back, and we went around the room, and again, secretaries and nurse care managers and pharmacists and physicians and corporate staff, and the group grew. We had more people come the second time, and that's, I think, because they knew that we would listen. And I had seen people, or we had seen people, physicians who said, you know, I want you to really talk about that, come to the meeting. I really feel, come to the meeting. So we pushed people to show up, and then we said, you tell us how you think we should create some change so that we can take the burden of these quality measures off the office, or take the burden of other things off the office so that they can really do this new quality work. And so that our resources, our organization, really can support, and our processes really support our strategy. And what they came up with was really interesting. It was different than what we would have thought. Because what they asked us to do was, so I'm moving my slides. What they asked us to do is to say, let's really create the primary care practice of the future, and let's become that, and we will do that. And so what do we need to get there? And they felt patients need to come first. So everything we do, all the actions we take, we will put the patient in the center. And we ask the doctors, you feel comfortable with that? Yes. Nurse care managers, yes. Pharmacists, yes. And so this has to be real. This can't be, you know, sort of theoretical or some kind of fluffy, warm feeling until something else happens. Every single thing we do, we have to put the patient first. So I'll talk about the barriers to change for a moment, and then I'll talk to you about what they suggested. So one of the big barriers for change for us was autonomy, because our practices, the 23 at the time, really felt like they were part of Coastal, and we supplied to them administrative support like accounting and payroll and credentialing and stuff like that. But they really could make a lot of decisions on their own. And what we were going to start talking about in this meeting was standardizing things, which was a really big change for folks. So if we're going to standardize things, then they weren't going to be able to pick and choose anymore. They were reporting loyalty issues, and we had to be very thoughtful about how we would handle that with our office managers, because office managers had come up through the ranks. Many were medical assistants for doctors, worked there 20, 25 years. As we all agreed, we need to make change. If there was an individual physician who said, not so much, then the office manager could very likely say, well, you know, my loyalty is with this doctor, this is where I have to go, and we had to figure out ways to not have that happen. And fear, you know, any kind of change brings fear, and there are many people who can sit down and tell you 20 reasons why something couldn't be done, and we said, as we started these meetings, let's not think like that. Let's take our fear hat off for a moment and put it under our shoe and step on it hard, because we need to come up with solutions, because none of us can live through what we just lived through. None of us can go through this fire drill anymore. Skill levels and level of complexity also played a big role in how we started to think about things, because we're asking people in our offices who have varying levels of skill to really start to think in very sophisticated ways. And so we had to bring in education and training, and even wonder if in certain circumstances we didn't need to replace positions. The level of complexity of the quality, I don't think quality measures we really ever appreciated until we really got these groups together and they said, look, you just got to make this much more simple for us. So what did we do next? They made recommendations, this group. They said, look, we want you to centralize some services and take the work out of the office. We've trusted you for years with our accounting and our payroll and credentialing and HR. Now we want to trust you with this too. So they asked us, take prescription refills, take prior authorizations, take insulin titration and diabetes management, take all fax functions and scanning that goes into the record, into the medical record, take transitions of care so that anybody, any patient going to and from the hospital or ER, there's a team that is working with them. At first, we were a little bit overwhelmed because we had never at a corporate level taken on these clinical functions, but this is what they wanted. And we wanted to respect the idea that we brought these people together and asked them what would work best for them. Coastal has always piloted programs, so we didn't want to take on these 6 new big projects and just blow everything up. So we said to each of the practices, look, we need your involvement. This is kind of scary to us. We're honest about that. We know you think the world of us, but this is new stuff. So we're going to pilot all of these programs, and we want every practice to be part of one of them so that all of you are part of it, and there's not one practice who is like the guy who's always like the great guy to work with. He's going to be in all of them, and he just doesn't have the time. And then the grumpy guy is on the side not participating. We said, no, everybody's got to be in one pilot, and everyone agreed. So we created these 6 pilots. We created teams so that there would be PDSAs and continuous quality improvement. We promised the doctors and the staffs that no matter what happened, if it didn't work, if it was a bad pilot, we'd get rid of it. If it was a pilot that needed improvement, we would do it right away. We would be listening, we would be receptive, and we would have continuous improvement and change. And then we would be willing to scale it when it got to the place that it wanted. And so it really worked for us tremendously well. We centralized, as I said, pre-visit planning, prior authorization, prescription refills, diabetes management. It's really not important what we did. It's interesting because the first 6 programs were so successful here that we then added specialty, quality team, and lab and diagnostic tracking that we do internally. And it's so funny because when we first started these programs, and I'm sure that people will relate to this who are listening, there were a couple of grumpy people who said, I will never participate in this program. I would never. So my response is, look, you can come to the meetings and be part of the group that's working on this, but by the way, if you do, you have to be in the pilot. Secondly, why don't you focus on your area for now and improve the pilot that you're working on, and then we'll see if we get the bugs out and maybe you feel differently. When Dr. McGuckin, who's our Chief Medical Officer, and I have gone to every practice of late and asked people what they felt about the pilots, and we've been scaling them, and they've worked really well. And our response has been, why aren't I in that program? So it's so funny. We've gone from resistance in some instances, participation in some, to I absolutely have to be in this program. So they've been so successful. Well, why have they been so successful? Mainly because it came from them. I think that's, we executed well and we audited. That was a big part of what we did, and we did the PDSA cycles. But the truth is that the reason they were so successful is that it came from the ground up, that these weren't directives. We, at the highest level, created the vision and the mission, and we confirmed what our values are. But we listened to the people on the ground who really knew what they needed, and then we did what they wanted. We also thank people. We did very well last year in shared savings, and we gave every single employee at Coastal, every single one, a week's pay from that money, and we're doing the same thing right now. We're getting ready to do a major distribution right now, and we will reward people in the same way. Every physician will get a thank you, every employee will get a thank you because everyone, every secretary, every medical assistant, everybody participated. And I'll tell you, when your staff are happy and they feel valued and they feel like they are participating and that they are heard and that they have a voice, doctors are happy. And we also learned that when your patients are really happy, because all of this translated to much, much better patient care, we found that physicians were happy too. So how do you get physicians happy, staff happy, and patients happy? We leaned into conflict too. That's the hardest thing. I'm actually going to a little seminar next week on having clear conversations. You can't avoid it. If you have a naysayer who's out there kind of creating some poison or destruction, we met with them right away. We met with them right away. We said, look, you know, if you're not in, you're out. And we even offered for some people that if they really felt like this wasn't for them, that was okay, they could go. And for our management teams, we did the same. We said, we'd love to have you on the bus. We'll give you all the skills that we can possibly give you. But if you don't feel you can be part of this change, that's okay. We'll appreciate that, and we'll help you make a transition to something outside the organization. Being resilient is important. I think that that's really hard because you have to just be persistent and be constantly positive and optimistic because, you know, fear and change can create so much anxiety and emotion. I went to actually see a speaker from Harvard the other day because I was speaking at on a panel for women's leadership, and she was talking about tools for resiliency. And I think actually I was so impressed that I would probably bring her in here to do something on resiliency with all staff because we need these tools for us to continue to just, you know, forge ahead. And most importantly, I think that you can't forget your mission and your purpose because, you know, most of us in healthcare, we're working for a nobler cause. This isn't about getting a paycheck. At least it's not for anybody who works here. They could probably make some more money in many other places. But when you can go to work and really engage patients and make a difference in their lives, that's got to really mean something important and has a tremendous value. And so we here at Coastal are constantly talking about that and honoring people who bring empathy, compassion, and caring to this work. And the results speak volumes. You know, our diabetics who are greater than 9 right now are 9.6%. I mean, that's just top in the country. Colonoscopies, the same thing. We're running 82% colonoscopies for our patients. Again, probably top 1% of the country. Pneumovac's the same. Mammography the same. Our ER visits are down right now for all of our contracts, 14% of where we started. And these aren't ER visits where people really need to go to the ER, because if they do, we need them to go to the ER. This is unnecessary, that they should really be seen in their primary care medical home. And our hospital admissions for our whole book of business are down 26%. That may be good or bad in your industry. So you need buy-in and participation for success. And again, we shared our ACO distribution with every employee, and we're getting ready to do the same on October 8th and 9th. I'll be out there with our executive team, and we will be thanking each and every employee at Coastal. I think that's it for me, so I don't know if there are any questions, or you folks, if you don't have questions, would just like to write some comments about what you thought we said or your own experience. We'd be very happy to hear that as well. Please.
Thank you. The floor is now open for questions. If you do have a question, you may press *1 on your telephone keypad at this time. Questions will be taken in the order that they're received. If you're using a speakerphone, we ask that while posing your question, you pick up your handset to provide favorable sound quality. Again, ladies and gentlemen, if you do have a question or comment, please press *1 on your telephone keypad at this time. Please hold while we poll for questions. Again, ladies and gentlemen, it's *1.
Well, there appear to be no questions, Jim and Meryl, but I'd like to thank you for taking your time today to present this material.
Well, thank you very much.
Well, thank you.
All right.
Okay.
Pat, just one more time, make sure there's nobody on the line.
Yes, no further questions.
All right. Well, thank you, everyone, for joining us today, and thank you, Jim and Meryl.
Okay, bye-bye.
This does conclude today's conference. We